What are the main causative agents in meningitis? So meningitis, it would be in newborns, neonates, it's going to be group B strep, E. coli, which is gram-negative. Rod? What is E. coli? Rod, there we go. Okay, so E. coli, group B streptococcus, because it colonized the vaginal cavity, and Listeria monocytogenes, which is a gram-positive bacterium. In the adult population, it's going to be Streptococcus pneumonia, Neisseria meningitis, and Haemophilus influenza, which is less common. In the elderly population, it's going to be Streptococcus pneumoniae. Listeria is also quite common. So with pneumonia, it's different because it's quite actually the same with that Neisseria meningitis. Klebsiella and Pseudomonas are gram-negative rods. Alcoholics, Klebsiella is more common. Never seen a bronchoalveolar lavage for a pneumonia. It's very unlikely and severely ill. Moxilin is a broad-spectrum beta-lactam antibiotic that has improved penetrability through the cell wall, and it binds to penicillin-binding proteins and inhibits peptidoglycan cell wall synthesis. Side effects: GI rash, cause anaphylactic reaction in a small subset of patients. Macrolides are 50S ribosomal subunit inhibitors, and they prevent translation of bacterial polypeptides, thereby inhibiting bacterial growth. Are they static or cidal? I'm guessing it would be cidal. macrolides, because you need proteins. Bacterus. God, you know as I can ask. Oh, bacteriostatic. What? Okay, sure. Bacteriostatic. Would you continue amoxicillin if this was mycoplasma pneumonia? Hell no. You would switch to doxy or azithromycin. Right, they are going to be translation inhibitors. Would you consider gentamicin? And would I consider doxycycline? Gentamicin. I would consider doxycycline as a similar mechanism of action to your macrolides. Your gentamicin is dependent on the patient's renal function, and no, I would not consider it. Why not? Aminoglycosides require oxygen for uptake, and hence they are ineffective against anaerobes. They bind to the 30th subunit of the ribosome. Good. So your aminoglycosides are same as tetracyclines in the mechanism of action. They're going to inhibit the 30th ribosomal subunit. Side effects: nephrotoxicity, ototoxicity, neurotoxicity. Everything toxicity. Sure. 30 subunit inhibitors can cause nephrotoxicity, ototoxicity, neurotoxicity, neuromuscular problems. Well, we know they can affect the eyes and the ears. They can also affect the nerves and the neuromuscular junctions. What does gentamicin also do? It's all fine. You should go to ETG and see what the side effects of beta-lactam antibiotics are. This is a phone. We're going to throw that away. We don't do phones alone. Okay. If she's allergic to my first macrolide, I would consider another macrolide. So, or a different class of medication. So if azithromycin does not work, you may consider potentially other class of drugs. It may be likely that your roxithromycin, clarithromycin would also have similar side effect profile. So I might consider moving to tetracyclines, doxy, right? Yeah, you'd go to doxy. And then your fluoroquinolones, which are DNA gyrase inhibitors. DNA gyrase is topoisomerase type 4. And it prevents bacterial DNA. Yeah, that's all fine. Metronidazole are your... What's that class of medication? It's used for anaerobic bacteria. But No, it forms free radicals that will damage the DNA, right? Keep YouTube open. Completely forgot. Hi, where do I get my motivation from? It's not really motivation. I have 48 days to my exam, so I have to do it to graduate. Oh. And you want to be a good doctor and save lives when you get the opportunity, or improve patient care. How do I manage my time? Big question. I'm going to answer that probably on TikTok or another platform. Makes you sleep better. Thank you. And what am I eating? Turkey mince burger that I just forgot to add. I forgot to add the turkey in the burger, so it's just a mix, like a meatloaf. Alright, let's get back to work. What is metronidazole? I'll probably close this. What is metronidazole? This is layperson stuff. I need the actual goodies. Let's go to MIMS. Lower abdominal surgery and anaerobic coverage. What we suspected. Everything interacts with the cytochrome P450. Everything. Also causes QT prolongation. So it damages the helical nature of DNA and prevents protein synthesis. And it drives, which promotes free radical formation, and it damages the DNA helix, produces cytotoxic products. Right, it's used for anaerobic bacteria, lower abdominal. Okay. Just went into a rabbit hole. Let's answer this one. Tetracyclines, doxycycline can also stain teeth, bone growth, enamel dysplasia. So it can stain teeth and also cause enamel dysplasia and also affect bone growth. Fluoroquinolones, they are DNA gyrase inhibitors. What are their side effects? Everything causes GI superinfection, sure. Tendon rupture. How am I going to remember? Fluoroquinolones like ciprofloxacin can cause tendon rupture. ciprofloxacin, ciprofluoroquinolones. Just got to remember it, I guess. Tendon rupture and prolonged QT, as can your metronidazole. Most antibiotics, your macrolides, your fluoroquinolones, such as your ciprofloxacin, your metronidazole, and you can also see Clostridium-associated diarrhea, colitis, renal failure, seizures, history of tendinitis. Sure. So the key side effects of fluoroquinolones is that they can cause QT prolongation. We may also observe tendon rupture with fluoroquinolones like ciprofloxacin, tendon rupture, QT prolongation, and contraindicated in pregnancy. Anything else? Increase your seizure propensity. Curb 65. Confusion, urea, blood urea nitrogen greater than 7 millimoles per liter. Respiratory rate greater than 30. Is blood pressure less than 90 systolic? They'd be in shock. You would definitely have to. So it's a mortality stratification score, the curb 65. 2, they're an inpatient. 3, you consider ICU. And Smart Cop is another stratification tool. It requires bloods, and it's to assess the need for ICU admission, I believe. Greater than 5 points. High risk of reading respiratory and vasopressor support. No need intensive support. High risk. So Smart Cop stratifies patients based on their risk of requiring respiratory and vasopressor, so blood pressure. So with pneumonia, one of our concerns is we can get a clinical picture of shock. Septic shock, I would assume, with its bacterial. And so we need pressor support in addition to respiratory support. So that's what your Smart Cop is associated with. We'll do that case next. Right, anaphylaxis. Patient with a bee sting. They had a mild response. No, it's like your sensitization, I believe. Now, they present with tachycardia, tachypnea, pallor, which I'm concerned for shock, drowsiness, low GCS, angioedema, so they've got skin symptoms and respiratory symptoms. What is my diagnosis? Okay. My provisional diagnosis, given the presence of skin symptoms such as angioedema and respiratory symptoms such as tachypnea and biphasic stridor, align with the diagnosis of anaphylaxis. I'd like to exclude life-threatening differentials for respiratory symptoms, including pneumothorax, pulmonary embolus, pneumonia, and in this case, given bee sting and possibly an atopic type response, also asthma as well. Patient's age is not given. I'm also concerned about COPD, pulmonary fibrosis, and other causes of tachypnea and stridor might be stridor as an upper respiratory sign, so possibly foreign body obstruction, upper viral, upper respiratory tract infection. What investigations would I perform? So, bedside. What I understand, anaphylaxis is a clinical diagnosis. I would say My provisional diagnosis of anaphylaxis can be confirmed clinically through the presence of skin and respiratory signs, and in addition, a proportion of patients may also have gastrointestinal signs such as nausea, vomiting, diarrhea. To exclude my differentials, bedside, I might like to do a bedside VBG, looking for any evidence of respiratory failure, metabolic and respiratory acidosis. Look for signs of shock given the presence of tachycardia and tachypnea, so lactate would be important, and possibly blood glucose due to the drowsiness for the patient. I would then move to laboratory investigations including a full blood count, CRP looking for signs of infection. I would also consider I'd proceed to imaging and complete a chest x-ray to exclude life threats including a pneumothorax. If I'm concerned about a P, I can refer to Wells criteria, and if low risk, the P rule out criteria, and microbiology investigations to look for infective symptoms might include a throat swab and PCR microscopy culture sensitivity. So we did do UCs. Why am I doing this? I'll just go to keys notes. Medicine, BMJ, phase 3, biomedicine, biomemo, phase 3. This here. Anaphylaxis. Oh, I forgot status asthmaticus. Differentials generalized or idiopathic angioedema and urticaria. That's true. I've seen patients with other kinds of shock. Blood pressure wasn't given, but yes, anaphylaxis itself is a diagnosis of shock, right? It's distributive shock. So can be genetic causes, there can be respiratory causes, there can be systemic causes such as shock. Mast cell activation syndrome, mastocytosis, idiopathic urticaria, hereditary angioedema. Hell no, I've never heard of these. I'm not going to commit them to memory, but my brain will remember mast cell activation syndrome, idiopathic urticaria, angioedema, generalized angioedema. Okay, that's enough. Defining shock. The systemic allergic reaction that involves the systemic allergic reaction involving one or more organ systems. It occurs within seconds to minutes. 90% are uniphasic. 10 to 20% are biphasic. Are they talking about the stridor? Biphasic anaphylaxis. Oh, shh. After a couple of hours, they can return. Anaphylaxis part 2. That is not funny. That's scary. Anaphylaxis part 2. 90% are uniphasic, 10% are biphasic. So a small proportion of anaphylactic reactions can repeat within 1 to 8 hours, which is quite concerning. What is my diagnosis? If I could repeat my provisional diagnosis, given the presence of respiratory symptoms such as stridor, tachypnea, and skin symptoms seen with angioedema, is consistent with that of anaphylaxis. I would also like to exclude other respiratory causes of tachypnea, stridor, life threats, including pulmonary embolus. I would like to rule out pneumothorax, although there's no clinical picture consistent with this. I would like to exclude acute exacerbation of COPD, status asthmaticus, that can also result in shock, and other causes of shock given the patient's tachycardia, which is a compensatory response, and pallor include hypovolemic shock, cardiogenic shock, obstructive shock, and distributive, as mentioned, with anaphylaxis. I would like to also exclude idiopathic urticaria is also a diagnosis, which I may consider if I can exclude all the life threats and other causes. And genetic causes involved, including mast cell activation syndrome, generalized angioedema, generalized urticaria, hereditary angioedema. They did EUCs. Yeah, makes sense because hyperkalemia is not good. Yes, skin can cause erythema, hives, swelling, vomiting, abdominal pain, difficulty breathing, bronchospasm, swelling of the throat, hoarse voice, wheeze, and persistent cough, cardiovascular, low blood pressure, tachycardia, neurological, seizures. Otherwise, sense of impending doom. It's crazy how we get that anaphylactic shock and also myocardial infarct. Okay. Do you do an EUC for? Mast cell tryptase. Medical emergency, you do EUCs. ABG. Not a VBG. You could. VBG would give most information, but ABG would be preferred. It's a respiratory chest X-ray. Didn't mention EUCs. Right, in a life threat, you would just put on ECG, EUCs always. So I'd like to also order an ECG and EUCs as a medical emergency, which I should have identified. It's a mixed metabolic and respiratory acidosis where there's a low pH. Let's interpret this. Yeah, I did agree. Yeah, there is clearly an acidosis. There's a metabolic cause for it because it's low bicarb, and there's a respiratory cause. So it could be combined respiratory metabolic acidosis. So obviously no compensation. Oh my god. So high PaCO2 causes laryngeal edema. That's going to obstruct the airway, and that causes the inability to blow up CO2. That builds up more CO2. That worsens the acidosis and increases. Oh, it's a nasty positive feedback loop. So high arterial concentrations of CO2 can result in do they vasodilate when there's increased CO2? Yeah, because then you can remove more CO2. Let's go. Nope, useless. Alright, all normal except for low bicarb. Yeah, makes sense. And creatinine is elevated. Can't be back. Let's go. Okay. Yeah. What is the pathophysiology behind the clinical manifestations Well, anaphylaxis is a syndrome in which we get inappropriate mast cell activation to a stimulus. And mast cells can get activated through initial sensitization, and this may be through initial response to a trigger, in this case a bee sting, and this may result in eosinophils releasing Ig antibodies that can sensitize mast cells. And upon second exposure, when antigens that can trigger this inappropriate response bind to the antibody mast cell complex, we get degranulation of mast cells that can cause a systemic inappropriate response to the allergen, including respiratory signs such as stridor, obstruction, angioedema. Angioedema is not a skin symptom. It can cause respiratory symptoms such as angioedema, stridor, and also skin symptoms including urticaria. So what's the pathophysiology behind the clinical manifestations? Anaphylaxis is a systemic response that is driven through mast cell activation. The degranulation of mast cells and release of histamine results in inappropriate vasodilation in multiple organ systems of the body. In the skin, we can observe dermal edema. Dermal edema and wheal formation. In the respiratory tract, we may observe angioedema, occlusion of the bronchi due to bronchial edema. Yeah, it's bronchial edema, right? It's interesting. Bronchial obstruction is what we'd say. Laryngeal edema and then bronchial edema. And then hypertension. Alright, what is the pathophysiology about the clinical manifestations? Well, anaphylaxis is a systemic inappropriate response to an allergen involving one or more body systems, and it's driven through mast cell activation and the release of histamine. Histamine results in inappropriate vasodilation of multiple organ systems. In the skin, we may observe dermal edema, and we can see urticaria or wheal. In the respiratory tract, in the upper respiratory tract, we may observe laryngeal edema, which results in upper airway constriction and results in angioedema in the laryngeal area. In the bronchi, there is going to be increased secretions due to edema, which can cause a bronchial obstruction, and that can cause associated wheeze and an obstructive pattern of breathing. In the nervous system, we may observe decreased cerebral perfusion, lowering GCS, and systemically, all this edema results in a decreased intravascular volume, which can place the patient in shock. And there is also inappropriate vasodilation and drop in total peripheral resistance. What is the initial management? You get the EpiPen and you stab 0.5 milligrams in the outer thigh. And then you breathe a little bit. Initial management. So anaphylaxis is a life-threatening emergency, and I would begin by performing a very quick A, B, C, D, E. I'd be looking at the airways, looking for patency and observing for any evidence of angioedema, breathing, have a quick auscultation of the lungs, looking for respiratory signs consistent with anaphylaxis, including a wheeze. And C, I would establish it's not a trauma case. You wouldn't do A, B, C, D. In real life, I would jab the person with epinephrine, right? Okay. What are you doing? I'm going to do my ABCDs. I'm going to do it. Okay. So, the management of anaphylaxis involves anaphylaxis is a medical emergency. I would begin by performing a primary survey. I'd be assessing the patient's airway, ensuring there is patency. If not, a priority would be to ensure that there is a patent airway. I would be looking for evidence of anaphylaxis, including angioedema. With breathing, I would do a quick auscultation, listen to the chest, looking for any evidence of wheeze, rhonchi that are consistent with anaphylaxis. Cardiac, I may like to get an ECG of the patient, insert one 18 gauge cannula ready for fluid boluses, may give them 500 ml fluid bolus, assess capillary refill, which would be decreased. D, I would assess their GCS score, possibly get a blood glucose, and whilst doing this, I would like to concurrently treat the patient. So when I was on C prior to the ECG, I might like to add 0.5 milligrams of epinephrine in 0.1 milligrams per 1 milligram per ml to the solution. Okay. What do we do for management? Let's see. Common food, insects, shellfish, insects, medications. Uncommon. Oh no, imagine anaphylaxis to exercise. That sucks. Immunization. Idiopathic. Shellfish, milk, wheat, soy, sesame. Did they have any peanuts? Did they have any shellfish? Did they have any soy or sesame? Soy, wheat. Insects, bees, wasps, ants, ticks, antibiotics, and anesthesia. Anaphylaxis to anesthesia. What's the management? What is the appropriate emergency management of the situation? Really stressing this. Key. It's not useful in the short term. No, sorry. That's where we're at. Oh my god. Oh lord. You need to lay the patient flat. They can die in minutes if they're standing. They can die, human can die in minutes if they're standing with anaphylaxis. Number 1, lay the patient flat. Primary treatment, EpiPen, and then you do your primary survey. That's so much logical sense. Why did I not do it like that? So, primary survey, airway, breathing, you get respirate, O2, listen to the lungs, tracheal position, oxygenate, blood pressure, heart rate, pulses, peripheries. Yeah. Fluid resus, GCS, exposure, and glucose. When adrenaline fails to control the reaction, you can consider salbutamol or adrenaline via nebulizer for the bronchospasm, and intubation if they get worseningly hypoxic. Antihistamines such as cetirizine, diphenhydramine, cetirizine are your antihistamines. Phenylephrines are antihistamine. Yeah. And then you could consider corticosteroids, but no clear benefit. Antihistamine is not the first line for anaphylaxis. There is no evidence supporting its use in the management of anaphylaxis. It's still commonly used. Why not? It makes sense in theory, it doesn't harm the patient. Say the same thing about ivermectin and COVID. Okay, so primary treatment, EpiPen, 0.5 ml of 1 to 1,000 adrenaline mixture. Right. Right. That's much better. Much better. Oh my god, my eyes just got saved. So you must lay the patient flat. They can die in minutes if they're standing. And the primary treatment is to immediately administer the EpiPen. Secure the airway, breathing, control, salbutamol or adrenaline, corticosteroids, cetirizine or phenylhydramine. Explain the mechanism, adrenaline and side effects. Conduction, beta 2, RAN stimulation, bronchodilation, beta 1, kidney has beta 1 receptors, lungs are beta 2, alpha 1, increased antiperspirant resistance, and of course beta 2 in the lungs. So we'll call glycogenolysis. Will cause transient hypoglycemia, lipolysis, muscle stabilization, secondary arrhythmias, CNS can cause apprehension, liver, it can cause transient hypoglycemia due to B2 receptors, and GI nausea and vomiting. Prevent symptomatic blocking effects of histamine. There's 2 histamine receptors. H1 receptor is in mast cells, smooth muscle and endothelium. And H2 receptors are in upper GIT. and they can augment the effect of H1 blockers. Histamine can cause drowsiness and sedation. Diphenhydramine antihistamines have a sedative action. So Benadryl is not good if you have too much, because it can cause sedative kind of symptoms: dry eyes, dry mouth, constipation, and dizziness. Dry. They increase and upregulate. They downregulate and they increase the transcription translation of genes such as lipocortin that are going to decrease the production of cyclooxygenase, and they also inhibit phospholipase A2. What are acanthocytes? Eicosanoid. Inflammatory mediators from membrane phospholipids by lipase. The prostacyclins. Arachidonic acid derivatives. They're your eicosanoids. Eicosanoids are signaling molecules produced from arachidonic acid in action through phospholipase A2. They inhibit phospholipase A2, preventing arachidonic acid breakdown. So that's lipocortin, which can inhibit phospholipase A2. And they can cause so many symptoms, such as increasing blood pressure. They can increase your risk of blood glucose, diabetes. They can suppress the immune system, necrosis of the femoral head. Oh, so much. That's alright. I have to do what I can. Well, investigations: ABG, ECG, full blood count, LFTs, EUCs, plasma histamine. So, didn't we say it was tryptase? Mast cell tryptase. Serum tryptase, mast cell tryptase, which is an acute media released by mast cells. It's elevated in anaphylaxis, and it's high for up to 6 hours. It's more useful than plasma histamine. So much here. Already looked at that. Type 1 hypersensitivity, or with type 3 hypersensitivity is antibody-antigen complexes. Type 2 is like your golden standard, right? So you just have antibodies bind into antigens. Type 3 is antigen-antibody complexes. Type 1 is your IgE mediated. Binds to mast cells, this cross-linking of IgE and mast cells, and they're sensitized. Antigen presenting cells bind to MHC class 2, and they go to lymph nodes and present it to C cells, which will differentiate into T helper cells, and they cause B cell class switching from IgM to IgE. And that recruits eosinophils and stimulates B cells, which secrete antibody IgE into the blood. Meter interleukin 4, 13, 3, 4, 5, 4, 13, and 5. So IgE binds to just grind. Type 1 hypersensitive leads to antibody B cells. IgE binds to Fc receptors. Fc. The allergen binds to the IgE mast cell complex, causing IgE cross-linking, which triggers mast cell. So IgE cross-linking triggers mast cell degranulation, histamine release, leukotrienes. Leukotrienes are potent spasmogens, can cause bronchospasm. And B-cell plasmogens, interleukin 13. Leukocytes infiltrate from blood to tissue, causing mucosal inflammation, causing secretion. Second exposure causes an acute phase and late phase response. Acute phase in the first 15 minutes. The late phase occurs 6 hours later and involves interleukin 5, which causes eosinophil recruitment, and they can infiltrate into tissues, increasing mucus secretion. Mucus secretion, which is going to worsen the narrowing. Worsen narrowing and obstruction. Activated mast cells also synthesize cytokines, leukotrienes, prostaglandins. Okay. Mucosal surfaces. Venules, mucosal, cutaneous and mucosal surfaces, and venules. They're at the top. What is a treatment? Use antihistamine. Ranitidine is a D2 blocker of corticosteroids, which minimizes a late-stage response. Discharge. Salbutamol by nebulizer. Bronchospasm occurs. Salbutamol is given by nebulizer. Discharge planning. Manage comorbid asthma. So give them antihistamines, corticosteroids, salbutamol, and discharge planning and education. Don't go near those allergens. H1 receptor antagonists are cetirizine and diphenhydramine. H2 receptor antagonists include ranitidine. Can adrenaline be given IV Generally, IM is preferred due to controlled release, reduced toxic effects, has been given, but has side effects of arrhythmias IV. Severe cases, it can be IV diluted. So adrenaline is preferred IM due to easier access, greater control of the dosage. IV can cause propensity for arrhythmias to occur, so it's not fair. Oh my lord, so many questions. Radiolurgosorbent test, serum tryptase. In vivo, skin prick challenge testing. In vitro is the RAST, the radio-labeled, the radioallergosorbent test. Radioallergosorbent test. Radioallergosorbent test. RAST is the radioallergosorbent test, where we can use radio IgE antibodies that will bind. Okay, we're testing for IgE antibodies to bind to specific allergens. So radioallergosorbent. What does that even mean? Sorbent test. Who's actually lasting? It's crazy. You too, guys. Super appreciated. Siban and syrup. Grinding. Radioallergosorbent test. So we're testing your blood to look if you're allergic by looking for antibodies to specific substances. Okay, looking for IgE antibodies to specific allergens. That's what I'm gonna remember. Serum tryptase can also be done. What's this? Oh my lord, I need to the mast cell mediators and cytokines. Well, what is released by the mast cell? We release histamine, there's tryptase, there's interleukins, all of them, interferon, TNF-alpha, interleukins, interferon, tumor necrosis factor. I'm not going to remember that. IG production. No, we're not going to remember that. It's a waste of time. Leukotriene B4 is part of chemotaxis. I learned that first year, right? Leukotriene B4. Okay, interleukin 5 recruits eosinophils. How am I going to remember this? A, B, C, D, E. The word E is the fifth letter of the alphabet for eosinophils. Interleukin 5 causes eosinophil recruitment. Interleukin 4 will switch T cells to the Th2 subtype and they cause antibody class switching. So pretty much they cause class switching. Interleukin 4 and 13. 5 is eosinophil recruitment. Thromboxane is a spasmogen. Tryptase activates the complement and coagulation cascades and causes anaphylaxis. It's too much, way too much to remember in my head. Shock is systemic hyperfusion of tissues, which doesn't meet the body's metabolic demands. There's hypovolemia, and that causes reduced preload and cardiac output. And it can be due to hemorrhage, GI bleeds, retroperitoneal bleeds, severe diarrhea, dehydration, third space losses. Still don't understand. Third spacing is when fluid is in a body compartment where it cannot be used for any purpose. And it could be in the presence of bowel obstruction where there is a lot of edema and fluid in the actual bowel mucosa. I remember when a fifth year told me pancreatitis and third spacing. And I was like, what the hell? So now I understand. Third spacing involves the accumulation of fluid between cells, but more likely in abdominal organs. Okay. It's cardiogenic shock, distributive myopathies, arrhythmias, valvular disease, and actual just cardiomyopathy. Distributive shock, there's septic, anaphylactic, and neurogenic. Spinal injuries, there's warm obstruction to blood flow, and that causes no systemic cardiac output. And that's cardiac tamponade, pneumothorax, pulmonary embolism. Right, makes sense. Oh Lord, there's so much. Oh my God. In endothelium, you get DIC and shock. You can get watershed infarcts. You can get confusion, lungs. You can get pulmonary edema. Oh, this is a hard case. This is just one case which I thought would not be too hard. It's a decrease in perfusion of vital organs. It's the heart, lungs, you can get ARDS, brain, you can get confusion, heart, you can get MI, lungs, you can get ARDS. That makes sense. The edema can cause necrosis. Hyaline membrane formation, brain, kidneys, you can get the water tubular necrosis, gut, you can get can also lead to shock. Alkaline bacterial factors that play a role in causing shock. Liver polysaccharide, endotoxin, gram-negative bacteria, stimulates TNF and interleukin 1, which can cause widespread histamine release and can cause increased expression of tissue factor by macrophages and endothelium, which can lead to DIC. So why are we always concerned about DIC in the presence of shock, especially in sepsis? It can cause increased tissue factor production, tissue factor is factor 3, and it will find the factor 7 to activate factor 5 to activate factor 7, factor 7 to activate factor 10. Factor 10 will then go on to activate thrombin factor 2, and that will activate fibrin to fibrinogen, fibrinogen to fibrin. Okay. Toxic shock syndrome toxin and lipopolysaccharide and gram-negative bacteria. What are the microbial specimens that you would collect in a case of septic shock of unknown source? You would do cultures, full blood count, EUC, LFTs, baseline, lactates, coags. I would definitely have forgotten septic shock to do coags. Coags is the blue tube is coags. So I would order the blue tube at hospital, which is my coags, because I'm concerned about disseminated intravascular coagulation secondary to the septic shock. So with sepsis and septic shock, add on your coags, because you're worried about DIC. I'm so tired. ABG, urinalysis, culture sensitivity, culture everything. So pretty much you're looking at all the imports, right? So you want to culture the mouth, the urinary tract, you want to get urine MCS and urinalysis, and then you want to get a blood culture, and then you want to get a chest x-ray. And you want to also get coags, and everything else makes sense, and then potentially CSF, which is the other. To all of that, and then finally, what empirical therapy with septic shock? There's no obvious source. Cause of age is only identified in half the cases. It's due to E. coli, which is gram-negative. Klebsiella is gram-negative. Strep pneumoniae and staph. I think it's strep or staph, and then E. coli and Klebsiella. Klebsiella, not Klebsiella. Klebsiella pneumonia. Staphylococcus aureus, Klebsiella pneumonia. Need to choose empiric antibiotic therapy. The low risk of MRSA, you give diafluclox. The penicillin, you don't use diafluclox. You use cephalosporins. And in the case of immediate type hypersensitivity, use Vanc. And diafluclox, penicillins, oh my lord, I've finished. Right, I need like 2-minute break. 2 minutes. Actually, I've got 2 minutes left till I can take my break. Let's go. Let me actually try smashing out as many questions as I can in the last 2 minutes. So I will close all of this and see how good I go with this case. Anaphylaxis. A patient presents to the emergency department after a bee sting. They'd previously been stung, but they had a mild response. They now present with tachycardia, tachypnea, pallor, drowsiness, angioedema, and a biphasic stridor. My diagnosis, given the presence of recent bee sting, which may be a potential allergen, combined with the respiratory symptoms above of angioedema and tachypnea and stridor, would be that of anaphylaxis. I'm also concerned of other causes of shock, potentially status asthmaticus, and other respiratory causes that are life-threatening include pulmonary embolus, pneumonia, pneumothorax, in which the pneumothorax and pulmonary embolus can also cause a shock. I would like to also exclude other types of shock, such as hypovolemic shock, cardiogenic, obstructive, and other causes of distributive shock, including sepsis. Given the presence of stridor, I'd like to also exclude other upper respiratory tract pathology, which may include viral urtes, and as we mentioned, asthma, may also like to exclude COPD. What investigations would I perform? This is a medical emergency and warrants treatment concurrently with a primary Investigations. I didn't ask for anything else. So this is my anaphylaxis is a clinical diagnosis in which there is a known offending allergen and 2 or more body systems involved. However, I would still like to do basic investigations, including a blood glucose given the patient's drowsy. Might like to do a bedside VBG, looking for any evidence of metabolic or respiratory acidosis. I would also like to do a full blood count, CRP, look for any evidence of infective picture, EUCs, as this is a life medical emergency, chest x-ray to exclude pneumothorax, and given that I suspect a histamine mediated disease, I might like to also do mast cell tryptase levels. Interpret the ABG. This ABG depicts a picture of metabolic and respiratory acidosis in a combined fashion. And base excess is negative, which indicates that there is an additional acid, could be lactic acid, in case of shock. What is the pathophysiology of the clinical manifestations? It's edema everywhere. Laryngeal edema causing angioedema, difficulty breathing, dermal edema causing urticaria, could be bronchial, it could be spasmogens including thromboxane, but also histamine combined with secretions which can decrease ventilation. What my management would be concurrent treatment with adrenaline 1 mg per ml whilst also doing a primary survey. As initial management, what's the mechanism of adrenaline? Adrenaline is a non-specific sympathetomimetic. It's a catecholamine released by the adrenal medulla. It's not a sympathetomimetic. It's a catecholamine released by the adrenal medulla, and it acts on multiple receptors. Beta-1 receptors in the kidney can cause renin release. Beta-2 receptors in the lung and the liver. In the lung, they can cause bronchodilation, and in the liver, they can increase. In the liver, they may. In the liver, it may cause a transient hyperglycemia. And there's multiple other organ systems. Alpha-1 receptors in blood vessels decrease total peripheral resistance. Beta-1 receptors can increase cardiac output. What's the mechanism of adrenaline? What would be a follow-up management? I would immediately like to look for any evidence of late phase reaction, 1 to 8 hours after the initial reaction. And this is due to recruitment of more eosinophils that can also cause an inflammatory response. Adrenaline can be given IV. It's preferred to be given IM as you control the dose faster to put in. Stages of septic shock. Septic shock can be compensated or non-compensated, I believe. What are the stages of shock? Pre-shock, shock, and organ dysfunction. Close this. Okay, I'm taking my 5-minute break. And I'll recap at 1. Oh, wait. No, I need some extra intense songs. Cornfield Chase. Hans Zimmer. It's been pretty good. Alright, let's go. And put this away. Oh, I completely forgot. I don't have. That's better. Bring this down a notch. No. Alright. Let's go. No. So the key principle here is when we have increased baroreceptor firing, it's going to go to the vasomotor center and inhibit the sympathetic outflow. And that's going to increase the vagal tone and cause decreased noradrenaline adrenaline release, causing vasodilation, decrease in blood pressure. Makes sense logically. So increasing firing is going to inhibit the sympathetic nervous system or activate the parasympathetic. Sure. Let's set the 8-minute timer, do the anaphylaxis case. Why don't I just do both, you know? How about I do the whole pneumonia case too? Because that was quite a lot of new learning as well. That's how good my memory at 2 a.m. is. Put all of this up. Okay, 8-minute timer. Alright, let's go. A 30-year-old female presents with a 12-day low-grade fever. She's got a non-productive cough and is generalized lethargic, so considering respiratory pathology. She's got coarse crackles all over the lung fields. Seen by a GP, given amoxicillin. Wasn't real enough. She went to ED where chest x-ray reveals lower lobe consolidation. Heart rate, normal. Slightly elevated, possibly slightly tachycardic, blood pressure slightly elevated, respirators slightly elevated too. She's afebrile. My diagnosis, given the presence of a non-productive cough and diffuse crackles radiologically, is that of pneumonia. I would be considering an atypical pneumonia given the patient's age, present of atypical signs such as fever and headache, and differentials would include life-threatening respiratory causes, such as pulmonary embolus, pneumothorax, lactose-exclude infective causes such as pneumonia, and I would like to also consider an asthma exacerbation, COPD exacerbation, and other causes of headache, which include meningitis and encephalitis, etc. What organisms are responsible? In the case of atypical pneumonia, the causative organisms are predominantly bacterial, and this includes gram-positive Diplococci streptococcus pneumoniae. Also be caused by Haemophilus influenzae, which is gram-negative, organism. We also have Klebsiella or Pseudomonas, which are both gram-negative rods. And there's also atypical organisms, which include Mycoplasma pneumoniae, Chlamydia pneumoniae, Legionella, and also the Coxiella burnetii, which is also responsible for Q fever. How would I test for Mycoplasma? Given that Mycoplasma does not have a bacterial cell wall, it would be difficult to gram stain this organism. I could use genetic nucleic acid amplification testing in PCR, looking for Mycoplasma genetic information, DNA, and I may also like to do serology, looking for IgM, IgG antibodies to the pathogen. Sputum cultures are positive for Mycoplasma. How do you take sputum and blood cultures? Sputum cultures are taken by, usually in the morning, give the patient a saline mouthwash, and this is to prevent any contamination. They'll then take deep breaths and practice deep breathing, and they'll cough following the deep breath into a cup until we generate some productive sputum to culture. For blood cultures, we take a venipuncture from a sterile site, and we use blood culture bottles alongside your regular transfer devices, and using a butterfly we would collect blood, use it in a syringe, transfer it into blood culture bottles, aerobic first, followed by anaerobic first. Do your aerobic first, because there's air. Due to the presence of air in the tip of the syringe, you might like to do aerobic first and then anaerobic. So it's green and then orange. And you'll use alcohol to wipe the top off the blood culture bottles before transferring. How does amoxicillin work? The beta-lactam antibiotic binds penicillin binding protein, inhibits peptidoglycan synthesis. It's bactericidal. Macrolides are 50S ribosomal subunit inhibitors. As a result, they will inhibit bacterial translation, and they are bacteriostatic in nature. How would I continue amoxicillin? No, because amoxicillin targets the bacterial cell wall. Mycoplasma does not contain a cell wall. Would you consider gentamicin? I would consider gentamicin if my first-line therapies do not suffice. In the case of an allergic response, etc., or epidemiological data, if we're in a different demographic. I would consider using tetracyclines or macrolides for atypical coverage. This could include azithromycin or doxycycline. If she's allergic to the first macrolide, like allergic to all macrolides, so I would switch to using a tetracycline, which is a 30S ribosomal subunit inhibitor. What is the alternative cover? We mentioned tetracyclines. How does gentamicin work? Gentamicin, like tetracyclines, is also a 30S ribosomal subunit inhibitor. However, it carries more side effects. It's predominantly used for gram-negative bacterium, and it requires oxygen for uptake, so it's preferred for aerobic organisms. Side effects include ototoxicity, nephrotoxicity, neurotoxicity, neuromuscular toxicity, and I believe it's also contraindicated in pregnancy. What would cause abscess formation in pneumonia? Abscess formation is usually implicated with Staphylococcus pneumonia, and that's because Staphylococcus aureus can contain various enzymes such as coagulase, hyaluronidase, and lipases, DNases, that enable it to break through, invade through tissue, and form purulent exudate formation. How would I assess whether she should be in hospital at the home? I would refer to the CURB 65 score, which assesses confusion, blood urine nitrogen greater than 7 millimoles per litre, respiratory rate greater than 30, and blood pressure or systolic less than 90 in the age over 65. This is used to stratify mortality for patients with pneumonia. I would also consider using the SmartCop algorithm to assess the need for pressor and respiratory support. Score greater than 2 with SmartCop requires admission. A score greater than, and then SmartCop just stratifies. Next case. I did all of that in less than 8 minutes. I spoke way too fast, but I got the key points. I know the key points. That was pretty good. Played Darude, Sandstorm, Best Studying, Instrumental. Okay. Margie. I've heard of this song. It better not be a meme song. Let's see. Face is a bit. No. Wait. Well, that's pretty good, but it's more like electric. I like my Hans Zimmer. Oh. Anaphylaxis. Let's restart my timer. Patient presents to ED after a bee sting. Had been stung before, but they had a mild response. Now present with tachycardia, tachypnea, pallor, drowsiness, angioedema, and a biphasic stridor. What is my diagnosis? Given the presence of characteristic respiratory signs of angioedema, upper airway obstruction, of biphasic stridor, and pallor consistent with shock, I'm concerned about anaphylaxis as a cause of distributive shock for this patient. I'd like to exclude other causes of shock, namely status asthmaticus, and other life-threatening respiratory conditions including pulmonary embolus, pneumothorax, and infective causes such as pneumonia. I would like to also exclude infective exacerbations of COPD, and other causes of shock in this patient may include hypovolemic shock due to loss of fluids, dehydration, third spacing, cardiogenic shock, obstructive, and sepsis as a cause of distributive shock. What investigations would I perform? This is a medical emergency, so I would perform concurrent treatment whilst conducting a primary survey with investigations. Nonetheless, ordering the investigations, anaphylaxis is a clinical diagnosis, and as such, I would be focusing primarily on assessing the patient's respiratory status, baseline function. Bedside, I might like to get pulse oximetry. I would like to also get blood glucose given the patient is drowsy, and we may then proceed to full blood count, CRP looking for signs of infection, EUCs assessing for any arrhythmias that may be associated, cardiogenic shock, and also baseline function for the patient. And also like to get, given that I suspect anaphylaxis, mast cell tryptase may be relevant. May also consider microbiology investigations such as a blood culture. We've mentioned VBG, looking for any evidence of type 1, type 2 respiratory failure, acidosis secondary to metabolic lactate production, and what's the pathophysiology behind the clinical manifestations. Anaphylaxis is due to inappropriate mast cell activation and occurs secondary to an allergen which affects more than one body system. This results in generalized vasodilation and edema. In the skin, dermal edema can cause an urticarial type response with a wheal. In the respiratory tract, in the upper respiratory tract, we may observe laryngeal edema, which results in the angioedema can cause obstruction. There's also the release of potent spasmogens such as thromboxane A2 and histamine itself, which can cause bronchospasm and also increase secretions, which can decrease ventilation from the bronchi. It can also affect the gastrointestinal system, causing nausea and vomiting, and we may also observe edema resulting in decreased intravascular volume, which is going to lower the preload, cardiac output, blood pressure. Why is a patient reacting with anaphylaxis now and not previously? Well, upon first exposure to an allergen, this will be taken up through the lymphatic system to the adaptive immune cells. The T lymphocytes will be presented this allergen by antigen-presenting cells, which may include dendritic cells or macrophages. They will then release interleukin-4 and interleukin-13 to cause class switching into Th2 cells. Th2 cells will then release interleukin-5 to recruit eosinophils and also cause class switching of B cells to IgE antibody production. The IgEs will then bind to mast cells and sensitize them. Upon second exposure to a pathogen, we will get binding of the allergen or pathogen or toxin, whether it be an insect, to the IgE mast cell complex. We will then observe cross-linking of the IgE antibodies and degranulation of the mast cell, releasing its internal mediators, including histamine, tryptases, and carboxypeptidases, alongside multiple cytokines. What's my initial management? My initial management whilst conducting my primary survey is that of epinephrine 0.1 1 milligram per ml with a maximum dosage of 0.1 milligrams per ml with a maximum dosage of 0.5 milligrams in 5 ml. And I would also do airways, looking for open patency in the airways, and potentially consider intubation. With breathing, I might like to get the pulse oximetry, breast rate, chest x-ray, lung sounds, and then give epinephrine as well. We also consider nebulized epinephrine and salbutamol if the intramuscular dosages are not resulting in clinical improvement. What is the mechanism of adrenaline? Adrenaline is a non-specific alpha and beta agonist, and it's a catecholamine produced from the adrenal medulla. Adrenaline will act on beta-2 receptors, increasing cardiac output. It will also result in increased activation of alpha-1 receptors, causing vasoconstriction, and also beta-1 receptors located in the kidney, which will increase renin-angiotensin-aldosterone system production that may increase intravascular volume and pressure. GI system, it can affect blood flow, causing nausea, vomiting. Can it be given IV? Yes, sure. Risk of arrhythmias is high, so we prefer not to, and you have better control over the drug in the IM stage. Stage of shock. There is pre-shock, there is shock, and end organ dysfunction. Pre-shock is characterized by compensatory mechanisms to the shock, which can maintain blood pressure transiently. This includes the use of the activation of renin-angiotensin-aldosterone system, the release of ADH, which increases intravascular volume, etc. The decompensated mechanism is when we see evidence of shock and decreased perfusion, and then end organ failure, as mentioned. Is end organ failure? What else could it be? Two more cases. Come on. Two more cases. We're in time. I'm not at a 5-minute break anymore. $30 more minutes. 15 more minutes, 2 episodes. And I will add choose my answer. How long has man worked for? Alright, let's do this one. Pulmonary embolus. I might take a 1-minute break. Short break. I'll be back. Okay, let's get back to work. Sesh. Let's go. Reset. I'll put 2 12-minute timers because we've got 20 minutes left, so I'll put 8-minute timers would be good. So 30-year-old female presents with 3 weeks postpartum with pleuritic chest pain. Heart rate is 122. Pleuritic chest pain, I'm straight away thinking pulmonary embolus, pneumonia, pneumothorax, 3 Ps, pericarditis as well. Heart rate's 122, blood pressure is up quite normal. She's tachycardic. She's got an increase. She's tachypneic, tachycardic, afebrile. What's my diagnosis? Okay, my diagnosis for this patient, given her increased, her prothrombotic state, given she's 3 weeks postpartum, and pleuritic nature of pain with respiratory symptoms such as tachypnea, would be that of a pulmonary embolus. I'd like to exclude other life-threatening causes of respiratory symptoms, including myocardial infarct, aortic. I'd like to also exclude other life-threatening causes of chest pain, including myocardial infarct, pneumothorax, aortic dissection, and other causes of respiratory causes of pleuritic chest pain include pneumonia, as we mentioned, and cardiovascular, also pericarditis. What is my approach to a history and exam of this patient? The history, I'd like to know whether the patient is, I'd first characterize a presenting complaint. So pleuritic chest pain, I'd like to know whether it's positional, associated with pericarditis, whether there are other infective symptoms which can point to a picture of pneumonia, and then for pulmonary embolus, I'd like to ask for associated lower limb pain, whether the patient has had, given it's a pleuritic type chest pain, whether they've had any recent major surgeries. It was postpartum, I'd like to know whether it's cesarean or vaginal delivery. I'll then take an obstetric history, calculating gravidity parity, and would then proceed to family history, look for any genetic causes of prothrombotic state, factor V Leiden mutation, for example, hereditary thrombophilias. What are your risk factors for a PE? The Wells criteria is a stratification tool used in the ED setting that utilizes the predominant risk factors for pulmonary embolus. These may include disruptions to Virchow's triad, so any stasis, which could include immobility. This could be after long-haul flights, and then also any genetic causes of prothrombotic states. So as we mentioned, there's factor V related mutations, there's hereditary thrombophilias. Also, you have to structure this. The risk factors for a pulmonary embolus may be linked to Virchow's triad. So stasis can result in clot formation in form PE and DVTs. And this can include immobility, long-haul flights, and then causes of increased hypercoagulable states. Could be malignancies, recent malignancies, surgeries such as obstetric surgeries, the use of combined oral contraceptives, which are medications. Yes, things I can think of, right? Presence of DVTs. What are the investigations I perform? For pulmonary embolus, I would first, in the emergency department setting, refer to Wells criteria. And if the patient is high risk, as seen here, with characteristic symptoms, I would order a CT pulmonary angiogram. Patient is currently not pregnant, so I'm not concerned. And otherwise, I would consider a VQ scan as well. Bedside investigations would include a full blood. Bedside investigations would include an ECG to look for any evidence of right ventricular hypertrophy seen in submassive and massive pulmonary emboli. I would then order. I'd like to get oxygen saturations too, as the patient seems to be high respiratory rate. I would then order full blood count, looking for any evidence of infection. Troponins as well, as I was concerned about a myocardial infarct. I would also look for the ST elevations and ECG. I would also consider ordering microbiology investigations if there is evidence of fever, such as throat swab, potentially also order a VBG. It's a respiratory pathology. And then imaging could include a chest x-ray. Look for any evidence of pneumothorax. Interpret this ABG. This is clearly an alkalosis with... this is... Okay, we can observe there is a respiratory alkalosis. And it's uncompensated with hypoxemia. Emias of the blood. Hypoxemia. Jeez. Alright. 15 minutes, let's go. How would I treat this patient with a pulmonary embolus? If there is a current pulmonary embolus, I would want to thrombolize the patient using tissue plasminogen activators. Could be alteplase or tenecteplase. And these are going to activate plasminogen, which is going to convert fibrinogen, which is going to form plasmin, and will dissolve the fibrin clot. I would also consider anticoagulation with heparin, and consider bridging warfarin with bridging therapy with heparin, and I may also consider one of the direct orally acting anticoagulants. With ABG, what are the mechanisms of these drugs and their complications? So, your tissue plasminogen activator, as mentioned, activates plasmin, which will degrade the fibrin clot. Side effects could include increased bleeding propensity, so it'd be contraindicated if the patient had recent surgery, if they've ever had a subarachnoid hemorrhage, currently have any active bleeds. Warfarin has multiple side effects. It's monitored through its INR, and it can be given via tablets orally. It can cause skin necrosis. It can also increase bleeding risk, and also is broken down by the cytochrome P450 system, so it has a lot of drug adverse reactions. Heparin can cause heparin-induced thrombocytopenia, which is particularly seen with unfractionated heparin. And warfarin interacts with everything, which is also broken in via the cytochrome P450 pathway. So this could include phenobarbital, carbamazepine, phenytoin, valproate. Patient was on combined oral contraceptive. What would I say? I'd say This is putting you at an increased risk of thromboses, and it would likely have to be seized given that you're getting pulmonary emboli and you're at increased propensity to develop more clots. So for now, it will likely be ideal to seize, switch them to another form of contraception, like hopefully non-prothrombotic, and if they refuse, more close monitoring and initiation of pharmacotherapy. So what I miss? Diagnoses is all right. Sudden onset dyspnea is a massive pulmonary embolism. Risk factors: immobility, signs of obstructive shock. So you have a high heart rate and low blood pressure. Yeah, okay. Massive obstruction, submassive. Your right ventricular dysfunction with no systemic hypertension, and non-massive. None of your features. I'm also concerned about MIs, dissection, pericarditis we mentioned. I mentioned pneumothorax. I should probably mention tension, as that's the main one I'm worried about. Where there is an increase in the intrathoracic pressure due to air moving in, and that creates tension on surrounding organs, which can cause collapse. Also pneumonia, pleural effusion. I completely forgot MSK, rib fractures. Today was a rib fracture. If they come with pleuritic pain, you need to use your patient expertise. You've seen someone with a rib fracture, so say rib fracture with pleuritic pain. MSK, psychiatric, stuff that. It's cardiac respiratory. It's quite literally this person's broken it down as chest pain, which is good. What is my approach to history and exam? How are we going for time? 9 minutes. I'd like to do primary survey with airway, breathing, circulation. Oh, there we go. Yeah, so I'd like to do a primary survey with airway, breathing, circulation. Don't die, tell them to calculate the criteria. Is it a mnemonic? What's criteria? Huh? What is rib fracture anxiety? I would, in the history, get Wells criteria. They have suspected DVT, PE, do they have tachycardia, 3 days of surgery or mobilization in the past month, and thromboembolism has happened before. Do they have hemoptysis, and do they have any cancers? DVT, tachypnea, cancers. We said all of this. It's just the hemoptysis I missed. If they have hemoptysis, TB and PE would be main ones I'd be considering. Interpretation, less than 2 is low, so PE may not be the most likely cause. 2 to 6 is moderate. Anything greater than 2, you do a CTP. That's all you care about. Less than 2, you'd correlate with the PE rule-out criteria. If that's positive, you do a D-dimer. If that's negative, you don't do anything, right? And symptoms: dyspnea, pleuritic, warm, erythematous, swollen. Risk factors: signs of right ventricular failure, elevated jugular venous pressure, allowed P2. What is P2? It's a pulmonary valve closing. P1 is P2 heart sounds. P1, P2. P2 is closing. Aortic. P1 is your mitral and your tricuspid, and it's your aortic and pulmonary. Loud P2. Makes sense. Pneumothorax. We've got anaphylaxis. Does this look like an anaphylaxis case? Let's go back up. What are the risk factors for OP? Didn't we just go through the Wells criteria? Verker's triad, hypercoagulability, we didn't mention endothelial injury, surgery, venous stasis, immobilization, hypercoagulability, factor V Leiden, protein CNS deficiency, antithrombin 3 deficiency. That's what I need to mention. The prothrombotic bleeding propensity. What about the thrombophilia? Thrombophilia just means disease of the clotting. Doesn't mean that it's prothrombotic or antithrombotic. So, okay. 5 more minutes. Let's go. Come on. Endothelial, venous stasis, endothelial injury, hypercoagulability, and then age. What investigations would I perform? D-dimer, CTPA, ECG, we said all of this. Coags. I forgot coags. If they got a PE, you do the you do the CTPA or VQ scan. You'd also like to get pulse oximetry. You'd also like to get a chest x-ray. You'd also like to do the whole MI pathway, which is ECG and TROPS. But you'd also want to get coags because the patient's going to be medicated on an anticoagulant, in which the APTT or the INR becomes important. So with all patients who have chest pain from PE as a source, you need to think coag studies. Imaging, chest x-ray. Yeah, we went through that. Venous Doppler ultrasound, look at lower limbs, makes sense. Okay. Interpret this ABG. Type 1 respiratory failure. Completely missed that. Low oxygen is type 1 respiratory failure. Should be 8 to 100, 35 to 45. So less than 80 is type 1 respiratory failure. To kidney angina VQ mismatch, the arteries blocked out. Due to articulation, and there's to kidney angina VQ mismatch, the arteries blocked, but the CO2 exchange across the membrane. CO2 is lower. Why is that occurring? It's because we have blockage of a vessel and the existing blood can still remove its carbon dioxide across the diffusion barrier. 3 minutes. What are the mechanisms of these drugs and their complications? Warfarin, we said skin necrosis, cytochrome P450. So let's see. Heparin, antithrombin 3. It's activation of thrombin through its antithrombin 3 activator. Uses hemorrhage, skin lesions, osteoporosis, heparin-induced thrombocytopenia, kidney impairment, osteoporosis, skin lesions, hemorrhage. Protamine is an antidote. Warfarin is epoxide reductase inhibitor, prevents the vitamin K dependent modification of clotting factors 2, 7, 9, and 10, and it causes bleeding, rarely skin necrosis, hepatic dysfunction. It's a known teratogen, so you don't want to use that, and it can prothrombin X. So it causes bleeding. It's initially anticoagulatory. It can cause bleeding risk. It's a teratogen, warfarin, and it can cause skin necrosis and hepatic dysfunction. dabigatran, pixaban, factor 10A, alteplase, bleeding, life-threatening. The contraindications to alteplase: absolute malignancy, previous hemorrhage, bleeding, head trauma. What does warfarin interact with? It's brought by the CYP family. CYP induction, inhibition. Cytochrome induction is rifampicin, St. John's wort, and then cytochrome inhibition. Antibiotics, vitamin K interacts with that. You need to stop your estrogen and progesterone medication. Lowers production of protein C and S, which is anticoagulatory protein. So you're in a procoagulatory state. That's because estrogen inhibits protein C and S. Swap to progesterone, that's it. It's because estrogen is the one that increases your thromboembolic risk because it inhibits protein C and S, and those are antithrombotics. You get a prothrombotic state. Very quickly, what's the pathogenesis of TB? It's primary, miliary, post-primary, so tuberculosis, aerosol droplets, accrete into macrophages. Macrophages release proteases, we get a granulomatous inflammation, we get granulomas that accumulate to a primary lesion under the gone focus, and we get a fibrous capsule, and that becomes latent TB. And you get caseating nodules. The miliary TB, you can get night sweats, anorexia, dry cough and crackles, fever, night sweats, anorexia, weight loss, cough. You find millet seed lesions in all the lung fields. It can't contain the infection, it spreads via the blood and lymphatics, and it moves to multiple organs, and the post-primary is reactivation after a primary exposure. This occurs in the apex of the lungs, post-primary. So you get our initial primary infection in which the macrophages intake the Mycobacterium tuberculosis, they form inflammation, caseating necrosis occurs. Caseous necrosis occurs, we get to the accumulation of multiple macrophages with TB that form a gone focus. Multiple macrophages are gone complexes. And then if walled off, there will be no subsequent infection. If it's not controlled by the immune system, immunocompromised or children get miliary TB, we spread via blood and lymphatics all over the body. And once that's healed, we get latent TB. And then it will reactivate as post-primary TB in the apex of the lungs. So here we've got primary tuberculosis. If it gets worse, progressive primary. It's even worse, it's miliary TB. It can become secondary. What investigations would you perform? I would perform a acid-fast bacilli swab, quantiferin gold assay. What else? Mentos test. Duration over 2 to 3 days. Diagnosis TB. False positives if they had the BCG vaccine, and then interferon gamma release assays. In vitro quantiferin gold. Your blood with TB antigens, and you measure interferon gamma released by T cells. Okay, it detects, it's unaffected by BCG. It detects previous exposure or radioactive infection. It's unaffected by the COMET urine vaccination. So you can get false positives. It's because you get a stronger response. With the interferon gold assay, you create a blood with TB and you measure interferon gamma. Interferon gamma will not increase if you have BCG vaccine. So interferon gamma, diagnostic chest X-ray, acid-fast bacilli, 3 samples at least 1 hour apart, and you retain the carbon fuchsia. Gold standard is a sputum culture, but we use Lowenstein Jensen, and yeah, that's it. Diagnostic, use a chest X-ray. We can do acid-fast bacilli stain.
Lowenstein Jensen bacterial culture. It takes a long time, so you could use a quantiferin gold assay, release assay, and all of the mailto test, and then chest X-ray. It's a mechanism of treatment of TB. How does this all work? Okay, TB can be managed with isoniazid, the prodrug. It's mycobacterial, and it targets the mycolic acid production. And we get skin reactions, rifampicin, diarrhea, rash. It inhibits RNA polymerase that's DNA dependent, which is really all bacteria. Pyrazinamide, pyrazinic acid, pyrazinamidase, disrupt cell membrane transport, ethambutol, and synthesis of the arabinogalactan. Ethambutol results mucus pregnant ethambutol. Ethambutol prevents the production of arabinogalactan. Oh my god. Pyrazinamide, rifampicin, red tears, pyrazinamide, liver damage. Okay. I think I'm done for today. My brain is so fuzzy that it's starting to think of these drugs as people. I just thought about pyrazinamide as a person that always gets nausea, vomiting. Alright, that's enough studying for today. Thank you for joining, and I will see you next time.